Welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today, we will talk about the general aspects of atrial fibrillation, and for that, we count with the collaboration of Dr. Miguel Rodriguez Santamarta, cardiologist associated to the heart failure unit of the Hospital de León, Spain. Join us! Atrial fibrillation, also known as AF, is a cardiac arrhythmia characterized by a chaotic electrical activity inside atrial cavities and by displaying clinically as an irregular ventricular mechanical activity, frequently fast. As you know, atrial fibrillation is very common nowadays, and its impact is more noticeable in our society. It is estimated that 1 in 4 people will suffer atrial fibrillation in developed countries, and that it will affect nearly 17 million people by 2030 just in the European Union. Besides, many consider atrial fibrillation as a benign arrhythmia. Truth is that patients with this entity possess a higher risk of mortality by any cause, especially by cardiovascular causes such as stroke, heart failure, or even sudden death. Meanwhile, it is frequent that patients with atrial fibrillation have a decreased quality of life due to common troubles such as palpitations, ventricular dysfunction, stroke, or complications related to anticoagulant treatment. And as you can imagine, this involves a substantial raise of health expenses. But which are the regular clinical manifestations? These are really variable. It all depends, among other things, on the age of the patient, the existence of a previous cardiopathy, and the frequency or regularity of the heart rhythm. Thus, many patients are non-symptomatic. Others may present some of these clinical manifestations: regular palpitations, shortness of breath, especially patients with heart failure, chest pain, especially patients with ischemic heart disease, syncope in the context of a tachybrady syndrome and a long sinus stop, and not often, a cardiogenic stroke in patients with subclinical atrial fibrillation. In any case, the European Heart Rhythm Association has designed a clinical scale that allows us to know how much symptoms affect the quality of life of patients, which always results helpful. The diagnosis of atrial fibrillation is usually made by an electrocardiogram because the irregular RR intervals and the absence of P waves are the typical pattern of this entity. However, the electrocardiogram of 12 leads can also help estimate heart frequency and identify signs of ischemia, signs of structural cardiopathy, or cardiac conduction disorders. Some complementary tests are needed in patients with atrial fibrillation too. For example, analytics. In this case, it is good to know how the renal function of the patient is doing, because some drugs, including anticoagulants, must be adjusted according to glomerular filtration rate. Meanwhile, studies of thyroid function will allow us to discard possible triggers of the arrhythmia, for example, hyperthyroidism, or adjusting the dosage of some regularly used drugs such as antiarrhythmic. Other relevant analytic parameters can be electrolytes, because hypokalemia, hypomagnesemia, or hypercalcemia can develop digitalis poisoning. Finally, blood count can help us identify and control clinical situations, such as anemia in anticoagulated patients and with elevated bleeding risk. Transthoracic echocardiography is another routine test in patients with atrial fibrillation. This tool allows us to know if there is, or there is not, an associated structural cardiopathy. Further, it is important to discard the existence of rheumatic mitral stenosis because this constitutes, along with the existence of mechanical valve prostheses, a clinical picture traditionally known as valvular atrial fibrillation, which has prognostic and therapeutic implications. Another aspect of this class of implications is the temporal pattern of the arrhythmia. In this way, we have first diagnosed atrial fibrillation, which refers to the first diagnosed episode of the arrhythmia, independent of its duration and the severity of the symptoms. Paroxysmal atrial fibrillation, which refers to the episodes that end up inside the first 7 days, whether they end spontaneously or assisted by cardioversion. Persistent atrial fibrillation, which refers to episodes that end up after the first 7 days, generally after cardioversion. Long-standing persistent atrial fibrillation, which refers to patients that have been cardioverted after having more than a year with the arrhythmia continuously. And permanent atrial fibrillation. This pattern indicates that the strategy of heart rhythm control is discarded and that the arrhythmia is accepted by the patient as well as the doctors. Besides these temporal patterns, it is appropriate to identify possible precipitant causes according to clinical circumstances of the patient. In this way, we have different clinical types of atrial fibrillation, which are: first, atrial fibrillation secondary to structural heart disease, typical of patients with an increase of pressure and remodeling of the left atrium due to, for example, asystolic or diastolic dysfunction of the left ventricle, myocardial hypertrophy, or arterial hypertension. Second, focal atrial fibrillation due to localized triggers, in most cases originating from the pulmonary veins. Third, polygenic atrial fibrillation, typical in patients with early atrial fibrillation due to certain genetic variants that are currently in study. Fourth, postoperative atrial fibrillation, which refers to a new appearance atrial fibrillation episode in the context of a major surgery, probably triggered by acute factors such as inflammation, atrial oxidative stress, or high sympathetic tone. Fifth, valvular atrial fibrillation, typical in patients with an increase of pressure and remodeling of the left atrium due to mechanic valve prosthesis or rheumatic mitral stenosis. At this point, it is important to remember that other valvular cardiopathies are considered non-valvular atrial fibrillation. Sixth, atrial fibrillation in athletes related with the intensity and duration of the exercise, probably due to the increase of parasympathetic tone or atrial volume. And seventh, monogenic atrial fibrillation, frequent in those patients with antecedents of inherited cardiomyopathies, including, for example, channelopathies. As you know, one of the main causes of morbid mortality in patients with atrial fibrillation is stroke. That is why different prognostic scores have been designed with the intention of identifying and treating patients with elevated thromboembolic risk. In this way, the CHATS-BASC score is the most recommended currently. This score is just an acronym consisting of the thromboembolic factors that are now listed: congestive heart failure, hypertension, age 75 years or older, diabetes mellitus, stroke, transient ischemic attack or thromboembolism, vascular disease, age from 65 to 74 years, and sex category female. Some variables count 1 point and others 2. So, the higher the CHATS-BASC score value, the greater the risk of suffering a stroke. In this way, the anticoagulant treatment should be considered in patients with a CHA2DS2-VASc score of 1 point or more, except in women without other thromboembolic risk factors. However, the coin has two sides because besides the thromboembolic risk, there is a hemorrhagic risk. So, the election of the anticoagulant treatment will have to adjust individually according to the bleeding risk of each patient. Finally, it is mandatory to point that the therapeutic management of the atrial fibrillation includes many other aspects besides anticoagulation. In general terms, it could be said that the comprehensive treatment of the patient must be driven to the control of the symptoms and to increase life expectancy through the strategies mentioned now. First, acute rhythm and rate control in unstable patients. Second, lifestyle changes and treatment of coexisting diseases. Third, oral anticoagulation of patients with high thromboembolic risk. Fourth, rate control strategy. And fifth, rhythm control strategy. As you can see, therapeutic management of atrial fibrillation is very complex, and because of that, it results impossible to approach it all with detail in this video. It will be necessary to discuss it later. Now we must part company. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!